letting everybody know who we have on board today and what she will be doing for us. Permit me to do the welcoming of our presenter today. I'm introducing Emma Hennessy, CNS Ophthalmology. Ladies and gentlemen, it's a great pleasure for me to introduce Emma, who is a clinical nurse specialist in ophthalmology from Ireland. She holds a bachelor's in science in general nursing from University College Cork, and she's a registered general nurse with Nursing and Midwifery Board of Ireland. She has further honed her skills with postgraduate diploma in ophthalmic nursing from the Royal College of Surgeons, Ireland, as well as nursing diploma in healthcare management. With her extensive background, including previous roles as a clinical nurse manager in ophthalmology in Cork University Hospital, Emma brings invaluable insights to our exploration of glaucoma diagnosis and management. Currently serving as clinical nurse specialist in ophthalmology at University Hospital Limerick Hospital Groups, Emma's dedication to nurse education, particularly in the field of ophthalmology, is truly commendable. Please join me in extending a warm welcome to Emma Hennessy as she shares her expertise and experiences in advancing glaucoma diagnosis and management. We are eagerly anticipating the enlightenment she's going to be sharing with us today and what lies ahead of us. Everybody, I present to you Emma Hennessy.
The slides should be up there now, and I have shared them with the organisers as well if anyone wants a hard copy of them. So I'll be presenting this evening on advancements in glaucoma diagnosis and the management, and exploring novel techniques and treatment strategies. Should be up there now. Now, if I change the slides, can you see? I hope you can. No. So just a disclosure there at the start, in relation to this presentation, I declare no conflict of interest or in relation to any of the context of the subject. I'm not sponsored, unfortunately, by any of the companies if I mention them in this. So just a layout of the agenda for this evening. So I'm briefly going to go through what glaucoma is. It's extremely extensive. I'd need 4 or 5 hours in an evening to really go through what glaucoma is, the risk factors, the different types of glaucoma, diagnosing it, the importance of history taken, different diagnostics, different treatments. I'm going to focus in on chronic open angle glaucoma and my role and your role as nurses. And then I'm just going to highlight some interesting reading and interested websites at the end. So what is glaucoma? So glaucoma is a broad term. It's used to describe eye diseases that damage the optic nerve. I think it's really important to remember that. People think glaucoma is one illness. It's an overall term for several different diseases that damage the optic nerve. It's the leading cause of preventable and irreversible blindness. So glaucoma, as I said before, it's a group of eye conditions, damage to the optic nerve where it leaves the eye. The optic nerve carries information from the light-sensitive layer of the retina to the brain. People become obsessed with the pressure and the level of pressure in their eye, but your eye does need some pressure to function. So you don't want too low or too high. It's getting a good balance in the pressure. When the pressure goes too low in the eye, you get a thing called hypotony, and the patient can't see either. You'd often see this maybe in post-op patients where the patient goes, or maybe a trauma patient, where the pressure can go down to kind of single figures down to 4, 5, 6, and they have no vision either. Likewise, you may have patients with pressure of 60 and 70 and they have no vision. It's really about finding a good balance. There's huge discrepancies and arguments in the data about what's acceptable with regards to eye pressures. It all depends on several factors: the anatomy and physiology of the eye, the age of the patient, contact lens wearers. There's several factors, but you're kind of looking from 10 to 20, somewhere in between. A lot of recent research is encouraging us to look for lower pressures, kind of 8, 9, 10, 11. And then if you look at NICE guidelines, they kind of insist on not treating until the pressures go over 22, 25. So really, there's several factors that influence what's an acceptable pressure for a person. But you're kind of looking at the low teens and kind of 10 to the low teens. Risk factors for glaucoma, as with everything, age, family history is a huge influence in glaucoma, especially coming from the mother side of the family. African, Hispanic, and Asian heritages, high eye pressure. If a patient is farsighted or nearsighted, that comes back to the anatomy of the eye and the axial length. Is it physically a long or a short eye? People who work with me will often hear me harping on about the size and the width of the anterior chamber. And that comes back to if an eye is physically long or a physically short eye. If a patient has had an eye injury in the past, often people who have chemical injuries where the cornea maybe have been damaged, after a chemical injury a couple of years down the line, you will see those patients suffering with glaucoma. Steroid medication, just to be aware of, there is a term out there called steroid responders. People who are on steroids can often suffer with high eye pressures. So their body naturally responds to steroids and then they have higher pressures in their eye. Another part of the eye that can influence glaucoma is a thin cornea. So I'll talk about more of this later. The measurement of the cornea pachymetry using a handheld device. Research has seen that people with thinner corneas tend to develop glaucoma, whereas people with thicker corneas are least likely to develop glaucoma. Also, the thin and the thickness of the cornea can affect the intraocular pressure when you're measuring it using the eye care. I'll talk about more of that later. And with everything, if you have a history of diabetes, huge risk of glaucoma linked to it, migraines, high blood pressure, that's also in relation to ocular hypertension, poor blood circulation, and other health problems that affect the body. So controlling eye pressure, I really like this diagram. I think it's a nice illustration of trying to keep glaucoma. It's so hard to explain it, but trying to keep it simple. So aqueous fluid is produced in the back of the eye. It moves forward, comes up around the iris, up around the pupil, and back down the trabecular meshwork. So when there is someone suffering with glaucoma, the fluid is produced, but there's either a build-up of the fluid, it can't get out the trabecular meshwork because either it's blocked or often you'd hear the angles are closed. If it's blocked, it's open angle. If the angles are closed, you have closed angle glaucoma. And then the pressure of the fluid builds up in the eye, and that pressure then sends back on the optic nerve, and that's what causes the damage, and that's what causes the glaucoma. So this is just a nice illustration of the difference between open angle and closed angle glaucoma. So closed angle is I'll go with the open angle first. So open angle, the angles are nice and wide. Gonoscopy is, you might often see a doctor with a little kind of mirror lens in his hand. I know the consultant we work with in Limerick, he's often going around with it. And that's the little piece of equipment they use to check and see if the angles are open or closed. So the image there, the angle is nice and open. The trabecular meshwork is here, but it's probably blocked off. In a lot of Irish people, we would see a thing called pseudo-exfoliation. So there's tiny little pieces just blocking little, they're nearly like little pieces of dandruff when you look under the slit lamp. And they gather here and they block the angle and the aqueous fluid can't come up and around. And then other people, you would often see this now in people maybe with very dense cataract. So we know cataract is a clouding of the natural lens. When the natural lens gets very cloudy and thick, it puts pressure here on the angles, it closes the angle, and then the fluid can't get up and around the angle. So we have a closed angle. Also, maybe someone with a very short eye, they'd have a very shallow anterior chamber here. The angles would be closed and they'd be under pressure. And this is where you get your closed angle glaucoma. So this picture here just describes all the different types of glaucoma. So you have your chronic open angle glaucoma, which we probably see a lot of in the clinical setting. Acute closed angle glaucoma, this would be more the emergency, the sudden onset of pain. Secondary glaucoma, that could be in relation to maybe a previous, as I said, a chemical injury or an infection, or might be induced by drugs, such as your steroids and your steroid responders. And then just scar tissue as well, maybe if they had an injury or a surgery in the past. And congenital glaucoma, I'm not really going to focus on this here today. It's more to do with pediatrics, and it's very, very specialized. So your chronic open glaucoma, it's gradual in onset. It's that little blockages in the open angles, and the pressure builds up slowly over time. It's very, very slow in onset, and it usually affects the peripheral vision first, so people don't notice it at the start, and it's very gradual, so they don't really complain of anything until it's gone too far. So very slow in progress, and it's a lifelong condition. Closed angle, acute closed angle, this is when the angles close and there's a sudden increase in pressure. Often these people will present to the ED or the emergency department with nausea, blurring of vision, severe pain, and halos around the light. The nausea and the halos around the light, and you'd often as well, they'd have a very physically red eye. Just with the nausea, that's where, if you work in ophthalmology, you may have come across Diamox, and they're often given stat doses of Diamox to bring down the pressure and relieve the nausea. Also with the nausea, sometimes as well in severe cases, they may use mannitol. Some of you might be familiar with that from an ICU setting to bring down intracranial pressures. It's a medical emergency, as with glaucoma, acute angle, it can cause permanent blindness, and it happens fast and it's irreversible. Secondary glaucoma, as I mentioned earlier, it's from injury, infections, so maybe someone with your uveitis, anterior segment uveitis, tumors, drugs, steroids, inflammation, maybe someone with sarcoidosis or another inflammatory response in the body, and then scar tissue as well, which blocks the drainage channels, kind of similar to the chronic open angle. As with the chronic open angle, again, the gradual loss of vision, especially in the peripheries, and it affects the peripheral vision first, similar to the chronic open angle. This form of glaucoma, it's slow again in progress. And the congenital, I'm not really going to focus on it today. It's more to do with at birth. You'd see it often when they do checks in the neonatal or in the maternity ward. A baby would have enlarged eyes, cloudy cornea, sensitivity to light, and a lot of epiphora. And it must be treated soon after birth, and it's a very specialized area. This is a nice diagram here, I thought, that explains glaucoma and the different types, open and the closed angle. A lot of terms in glaucoma, it's very hard to keep up because some people use primary and secondary and other people don't use the term primary and secondary. So it's very hard to keep on top of it, but just to try and be aware. So glaucoma, again, open angles. So there is a gap, open angle here. So you open angle here, the angle's nice and open. So open angle, primary open angle glaucoma, normal tension glaucoma, the patient may be presenting with when you do your IOP checks with your intraocular pressure checks with an eye care, you may notice that their readings are okay. But then when a doctor goes and does a thorough examination, they may find that there is something blocking. Secondary then, that's your pigment dispersion syndromes. So you may have like the pseudoexfoliation, the little pieces of dandruff blocking the open angles. Someone who has a history of uveitis, and then the treatment then is to lower the intraocular pressure. So usually your primary and your first response is to start eye drops, then maybe trabecular laser. So in Nina, where I work in Limerick, they do a lot of trabecular lasers, so that's your SLT. selective laser therapy, and then other people do ALT, argon laser therapy. And then final resort would be your glaucoma surgeries, like your insertion of an eye stent, your minimal invasive glaucoma surgeries, or your trabeculectomies. Closed angle, this is your emergency presentation. So you would have your primary angle closure glaucoma. So again, this would be the person who presented with the sudden onset, and the vision loss and the halos and the nausea. Or it could be also closed angle, could be your rubeotic glaucoma. So this may be a patient who is, very often the rubeotic glaucomas be a patient with diabetes. So as we know in diabetes, in the back of the eye, they get a thing called neovascularization, where little blood vessels grow at the back of the eye. And then sometimes when it really is happening a long time, these little blood vessels can start to grow at the front of the eye. And they get these extra little blood vessels around the meshwork here. And they get rubeotic glaucoma, extremely painful. So again, treatment options is to open the drainage pathway. So they may have a peripheral laser iridotomy, and that is done often in clinic, where they might have a little hole put in the iris. No picture of the eye there now, but they might have a little hole, just a little hole here, to give an extra channel for the aqueous fluid to pass out. And they may have lens extraction. So as I was saying earlier, the thick lens may be removed and a smaller, thinner lens may be put in, giving more space in the anterior chamber. They will also be commenced on lower intraocular pressure drops. And then the last resort, the glaucoma trabeculectomy surgery. If anyone has done any eye courses here in Moorfields, the Centre of Excellence for Eyes, one of the biggest things they highlight, and one of the things that are most important, especially as an eye nurse, is your history taken. It's so basic, it's so easily done, but it's so important. I used to work with a consultant, and he always described it as the scene of the crime, and always highlighted and drilled into us the importance of a history taken. So when you first meet your patient, a list of their medication. When you get a list of their medication, you can work back in, speak with them and discuss their medical history, their surgical history. Also in ophthalmology, it's very important to know and to realise the patient's social history. So is this person retired? Does this patient live alone? Is this person a driver? Does this patient live in quite a rural setting and depend on driving and depend on their vision? And then their ophthalmic history. Was this a person who wore glasses as a child, or did they only start wearing glasses in the last few years? Did this patient have laser corrective vision maybe 10 years ago? Did this patient maybe 20 years have an injury playing soccer or football? It's so important to get a good history, and it's from there you make your decisions and your plans and you work forward, and it often gives you a good indication of what tests to do straight away when the patient arrives. So then diagnosing, so important in glaucoma is the early detection as it slows the progress. So encouraging especially your older patients to attend for regular eye tests, and to always remember that glaucoma is symptomless at the start because it affects the peripheral vision first. Late stage then of glaucoma, it's completely irreversible, sight loss, and then leads to blindness. I'm going to speak more about it later, but one of the common tests for peripheral vision is the Humphrey Visual Fields test. There's a picture of the machine there. So the patient places their chin here on the chin rest, places their forehead here. There's a little arm that extends where in most of the machines where there is a liquid lens. And you can, if a patient has a prescription for glasses, you can input the information into the machine and it'll calculate the liquid lens, and the liquid lens will act like the patient's glasses, so they don't have to have their glasses on during the test. Down here is a picture of a fairly normal Humphrey Visual Field test result. We all have that natural black blind spot. Don't panic if you see that. It's usually an indication of which is the right and which is the left. And then just up here, I think what I find in ophthalmology anyway is if you know what the good should look like, you'll always recognize what the bad should look like. It's very hard to learn all the wrong versions, but if you know the one right version, you can always compare. So that's what a fairly normal, acceptable, happy Humphrey Visual Fields looks like. And up here is a picture of a patient who is suffering there with, you can see where they didn't get the clicks when they were clicking the machine for the flashing light. And this will give you an indication of where there has been some optic nerve damage. So then when the patient arrives, very first thing to do when a patient arrives in an ophthalmology setting is always visual acuity. Even if the patient has been in the day before, you always do a visual acuity test on them every single time they arrive. There is 2 examples there of different charts. I suppose it depends on the area you're working in and the teams you're working with. This one here is a Snellen chart, and this one here is a Logmar. The Snellen is around a lot longer, and it's probably the basic one, and it's the one that most places use. And then the Logmar here is a lot of research now. It actually developed for research purposes, and a lot of the data and research that's been done on it was promoting the use of the Logmar. The reason is, if you look, the Snellen, there's only 1 letter on the first line, 2 on the second, 3 on the third. Whereas with the Logmar, there's the same number of letters on each line. There's 5 letters on each line. So a lot of retinal surgeons prefer, and retinal specialists and medical retina people prefer a Logmar because there's the same number of letters on each line. So if someone has a scotoma, maybe age-related macular changes where they have a black spot, if you do their vision and they have a black spot in the center and they start missing all the letters in the center, it becomes very obvious very quick. Whereas with the Snellen, it may not become as obvious. But then the other side of it is the Snellen is probably the one most places have, like your GP setting, or your occupational department in a building. So often people, when they are referred to the eye department, the vision has first been done on a Snellen chart. But it's just good to know what the standard operating procedure is where you work, and just to be aware that when a patient arrives, was the eye test done in a Snellen or was it done in a Logmar? And the last day when they had their test done, was it done in a Snellen or on a Logmar? So then you also do their vision aided, and you always do it unaided and then with glasses or with the pinhole. Always do someone's vision without the glasses first, especially if it's their first time arriving, and then do it with the glasses. And then also, just to be careful, often people forget when they come into an eye department or an eye clinic that they're wearing contact lenses, and you may not realize this until you're 3 or 4 different tests in that they actually have contact lenses in. Another very good examination to do when a patient first arrives is tonometry. That's the checking of eye pressure, the intraocular pressure. Most places now, our department have an eye care. It gives quite good results. It's not the gold standard, but it is very good. And it's quick and easy to use, painless for the patient, very user-friendly, and it gives you a good guideline. Gold standard then for checking eye pressure is Goldman tonometry. So this involves you put anesthetic eye drops in the patient's eye, then you put in fluorescein, you get the patient to sit at the slit lamp. You have a little probe here that sits on the tonometer. You get the patient to sit comfortable. It's very easy to do it on glaucoma patients because they're used to having this test done. It can be quite hard and quite nerve-wracking to do it the first time on someone maybe who isn't used to having it done. Biggest tip is to make sure that you give them plenty of local anesthetic and it's been there a while. So it just involves getting the patient to sit at the slit lamp and you turn the tonometer around. This end here just tips off the cornea, and when you're looking through the slit lamp, you start to see these 2 semicircles, and you want them just to touch nicely like that. To get the circles to touch, you're twiddling this dial here, you're going up or down, and then the figure that is here, when you have the 2 circles like this, corresponds with what the pressure is. So you may, on a normal person, you may have the dial to get this image, and this, when you're looking through the slit lamp, you may have this at maybe like an 11 or 12, whereas maybe someone with acute glaucoma, to get this image, you may be going up to 30 or 40. I just mentioned earlier about pachymetry, and the central thickness of corneas. This is just a little device called a pachymeter, and you just use it as the person is demonstrating there, and you just tip the cornea, and it gives you a nice indication of the central cornea thickness, CCT. Then the next picture there is the ocular coherence topography. I have a link there to a really good video about how to read OCTs, especially in relation to glaucoma. Again, I'd need nearly another evening to just fully explain the different OCTs and the different interpretations of them. And like everything, I just find the best way to learn is to know what the normal looks like. So at a glance, this is what a normal looks like, and this is what not so normal looks like. So with the disc cupping, you may often hear that term used in glaucoma. So you want the disc to look like a nice Homer Simpson donut. And then as you can see here, it's not so clearly defined. Then also in glaucoma, you may hear of a term called the isn't rule. And this is normal. It's when you're looking here, it's inferior, superior, nasal, and you're just looking at the different, how the machine picks up on the green, the yellows, and the red. Again, there's a really good video there linked, and I suppose in the nursing role, it's more taking the good image, and just if you do see something obvious, but it's usually the doctors who read this. And that is the picture then of the OCT machine, patient sitting comfortable. The user there taking the pictures, that's a macula, OCT of the macula. You can see the nice dip of the fovea on the screen there, whereas this is the OCT of the disc. When the patient is looking in, when it is for the macula, they're looking straight ahead and they see a green X, whereas for the disc, the green X will be off to the side because of the anatomy and physiology of the eye. So as I mentioned earlier, one of the main tests in glaucoma and peripheral vision is your perimetry test. So that is your Humphrey visual fields machine there. It measures the extent of the visual field loss. It is so important in all of ophthalmology that your patient is positioned correctly before you do any test. It makes a huge difference in all results. Especially in ophthalmology, I suppose we get a lot of elderly patients and their comfort and their tolerance to sitting in awkward positions, and then I suppose with spinal issues and mobility issues. So it's just so important to have your patient positioned correctly. The other thing with the visual fields is it's quite a tough test. I don't know if anyone here has had it done. It's not an easy test. As I was saying earlier, the chin is here, the forehead is pressed here, there's sensors here and here. They look through the little arm here that has the liquid lens in it that's corrected to their prescription. So then you are checking their glasses prescription before they do it. And then the arm moves over for left and right. So they're sitting there, then they have the little clicker in their hand. They're focusing through the hand into the liquid lens at a light, and they focus on that. The first part of the visual fields test is it tests their fixation. So they focus through on the light. The machine gathers their fixation, and then when the test starts, so you input the patient's details and their date of birth. When you put in their date of birth, the machine then has a fair idea of what to expect a patient at that age to see peripherally. So the machine then will start flashing lights in the bowl. The patient has to stay focused on one light, but every time they see a flash peripherally, they have to press the clicker. It's not easy. It goes on for quite a while. The tests go on for different lengths. You will hear of fast, and you'll hear of CETA. They're the different terms for the test. Then you'll hear of probably the regular one, or the most common one will be the 24-2. Then you'll hear the 10-2 and the 22, and then sometimes you'll hear the 32-2. So they're all different tests, different types of Humphrey visual field tests that focus on different parts of the visual field and different parts of the eye. And some of them do take quite some time. They can take up to 20 minutes, 40 minutes. And when you have that elderly patient, you really want them sitting comfortably and paying attention. Then as well, if you have someone maybe who has cataracts or has problems with the anterior segment of the eye, or maybe has something like a nystagmus where the eye is bouncing all over the place, it can be very difficult to do the fixation. Also, when you're doing the Humphrey visual fields, the eye that you're not testing, you cover that eye with a patch. So then we're moving on to treatments. So the most basic and standard and nice guidelines would state that your first port of call with regards to treatment is your eye drops. So I just found this picture online. I just thought it was a really nice way of explaining glaucoma treatments. So a lot of people, I think you can get it from different eye charities or blindness charities. You'd see them wearing these kind of the X-Men Bono style glasses just to help with the halos and the light and the glare they experience from the glaucoma. So often they'll be wearing sunglasses. Then you start in with their eye drops. So you've the agonists there, the alpha androgenic receptors, and these help reduce the production of the aqueous fluid and improve its output. So then that would be your alpha-GAN eye drops. Then you move on to your beta blocker eye drops. So these would be like your Timo fluid, timolol, and these help reduce the production of intraocular fluid. And just to remember as well, these eye drops are beta blockers, and like all beta blockers, cardiac meds, you just want to keep an eye on your patient, make sure there's someone that's not a patient with an extensive cardiac history before they start these eye drops. Lights then should always be of good quality. Then you move on to your Diamox, your carbonic anhydrase inhibitors. Just be aware with Diamox, there's two types. There's a slow release and then there's a fast tablet form Diamox. Sorry, a slow release and a regular. There's no fast. So you might have Diamox SR or just Diamox. It's usually given in 250s, and then the max is 1 gram a day for 24 hours. You will have consultants charting higher doses in emergency settings and where they feel it's needed. Just to be aware, if you have anyone with renal issues or renal impairments or transplant history. Also with Diamox, it does flush the potassium out of the body. Often patients who are on Diamox for a long time will go on slow K just to keep their potassium levels okay. Also with the potassium leaving the body, just be careful as well. It's not a patient who's a diabetic or elderly, or with the cardiac history again. Diamox as well, because it acts as a diuretic, the patient, just to warn them that they will experience going to the bathroom more frequently. Just recommend that they drink plenty of water. I usually encourage them when they start Diamox to maybe eat a banana every day, just with the potassium. I don't know, does it make a difference, but I just like to encourage that. And also with the Diamox, the patient always has it with food. A yogurt, a banana, a piece of toast. Never give Diamox on an empty stomach. You'll find out very quickly why. It will make the patient vomit. And then the other thing with Diamox is it can be given in IV form. It is never to be given by a nurse in IV form. Let the doctors give it. There is no agent to reverse it once it's given. I've had plenty of arguments with doctors about this. I've done research in this. There is no reverser for it, so nurses should not be given it. And then just things that the patient avoids working for long periods of time on a computer. Then you move on to your prostaglandin eye drops. These help reduce the intraocular pressure. So your Xelantan, Lantanoprost. Also, you'll know when a patient arrives in front of you that they have been on the prostaglandin eye drops, because they will have the most beautiful, thick, black eyelashes. The other thing with the prostaglandin, it can change the color of their iris and it can lead to fat atrophy. So you may notice the skin around their eye area can get quite thin, or it can get kind of a purpley hue. It does give you beautiful eyelashes, but at the same time, especially with patients with glaucoma, they get these beautiful thick eyelashes, but the lashes may not be growing in the correct direction. So they can end up with trichiasis or ingrown eyelashes. So just to keep an eye on that. There's nothing worse than a patient with ingrown eyelashes rubbing off their cornea, causing a corneal abrasion. And then finally, you move on to your Simbrinza, your carbonic anhydrase inhibitors, and these help reduce the production of the intraocular fluid. Just to be aware, there is serious stringent, stringent the right word, there is instructions in the correct storage of some of the glaucoma eye drops. Always keep them out of direct sunlight, and some of them, your Tapticom, they do have to be kept in the fridge. The other thing with the eye drops, and I'll be repeating this again later, is patients' compliance. It is so important. There is so many patients who start glaucoma treatments and don't continue it because the glaucoma eye drops can be quite severe on the eye and do sting and cause kind of an allergic conjunctivitis the first time the patient starts using them. It is so important when the patient is putting in the eye drop that they're aiming down here, that they bring down their lower eyelid and they're aiming for the bulbar conj where the conjuncts meet. You don't want, and I see it so much, the patient putting the eye drops straight onto the cornea. It will hurt. The patient will become sore. The patient won't continue with the compliance. It can cause problems with the cornea in the future if they're having these eye drops constantly hitting the cornea first. Always aim for the eye drops, bring down the lower eyelid and down to the bulbar conj. And also with the glaucoma eye drops, they do sting, they do cause the redness, and it's just the compliance and just the correct way of putting in the eye drops. So then moving on to other treatments, one that we use a lot here in MENA is the SLT laser. Close that there so you can see. Yeah. So the selective laser trabeculoplasty. So this is used on open angle closure glaucoma. It's done at early stages. It's for primary open angle or pigmentary pseudoexfoliation glaucoma. It's often used in patients, as I was saying earlier, who are intolerant to medication, or maybe elderly patients who aren't compliant. Compliance is an issue. And it may also be used in combination with other treatments. So often they may have the SLT, but they may need to continue their eye drops afterwards. It's a machine that can be used in the outpatient's clinical setting. It looks a bit like a slit lamp, so accessibility is good. There's no needles involved. It takes about 10 to 15 minutes to do. There's no needles, there's no general anesthetic. It has an 80% success rate with few long-term side effects. It's relatively new. It's only around since kind of the late 90s. So there's still a lot of research kind of still being done about the long-term effects. So it reduces intraocular pressure by approximately 30%. So the patient comes in, they have eye drops given to numb the eye, make the eye comfortable. Again, like the slit lamp, they sit their chin here, they press their head forward, and then the doctor, or in some places in the NHS, nurses have been trained to do this. They shoot the laser in to create little channels in the blocked open angles. Often afterwards, the patient will have an inflamed red eye. The eyes may be irritable, may be discomfort, and they will be sensitive to light. Patients are often given a prescription going home just to take to keep the eye comfortable. And they're often given iopidine eye drops as well, just to bring down the pressure. And they will be brought back to the clinic afterwards. Then the next bit there then is the eye stent. If you can see, it's extremely, extremely small. And when I worked in theatre, we had so much fun trying to load these for surgeons. So it comes, some of them come, the eye stent, some of them come preloaded, and that's what it looks like. So it's a little kind of bypass mechanism. It's called a trabecular micro bypass system, and it's a little device that is often done at the same time as cataract surgery, and it's put in and it just helps with primary open angle closure and helps with the pressure in the eye. You'd often hear the term MIGS used, minimal invasive glaucoma surgery. It's kind of buzzword in glaucoma surgery, and it's the way things are going, moving away from the trabeculectomy surgeries that I'll talk about later. As I mentioned earlier, the lens thickness, this picture here just demonstrates, I suppose she's just exaggerating. So the normal lens in the eye, it varies, but we could see patients in Nina, they could have lenses 5 millimeters, 4 millimeters, 3 millimeters thick. When the lens is extracted in cataract surgery and the artificial lens is put in, the artificial lens is usually less than a millimeter thick. So it gives more space and area for the aqueous fluid to flow around. Now, trabeculectomy, it's probably the main form of surgical intervention for glaucoma. It's around the longest. There is some surgeons who specialize in it. It's a surgical operation. I've never seen it done under local anesthetic. I've only ever seen it done under general anesthetic. It creates an alternative drainage channel for the aqueous fluid to drain from the eye. They have this little thing afterwards called a bleb. They're usually up under, usually superior, and they're under. You'll have to kind of lift the eyelid to see it, most of them. If the patients have them a long time and the tissue starts to get very, very scarred, sometimes they become obvious, but usually they're cosmetically pleasing and you kind of have to go looking to see the bleb. So it's an alternative drainage channel then that's created, and it bypasses the blocked natural drainage pathway. So it bypasses the trabecular meshwork. The eye pressure is reduced because of the new channel, the bleb that has been created. The drug mitomycin is often used. Mitomycin, just to be very careful if you're around it. It is, as far as I know, it's carcinogenic, I think. So often in where I've worked in the past, the doctors reconstitute it, and a lot of nurses, especially nurses maybe who are pregnant or maybe family planning, would leave the room while it's being used or being reconstituted. That's just something I've seen where I worked, and it's just an agent that helps prevent scarring. So there's no point in creating a new channel if it's going to scar over, and the mitomycin just helps prevent the scarring and the scar tissue from forming. Also, you may often see on a theatre list patients coming in for a needling of bleb. So maybe the bleb was done 4 or 5 years ago, maybe longer, and maybe nurses and doctors have been checking this patient's pressure and they've noticed the pressure in the eye has been slowly going up again. So the patient may be brought back in where they do a procedure where this area, the bleb, is just needled, as it says on the tin, needling of the bleb, just to make sure the drainage pathways are still open and still functioning. Also with the trabeculectomy, I haven't seen it done as a day case. The patient usually stays in. They continue their glaucoma treatment after it, just to monitor that the pressure is going down. And sometimes, often, if the procedure is overly successful, you can have incidences where the pressure can drop quite significantly, or you will get episodes of hypotony where the pressure could go down to 2, 3, 4 suddenly after the surgery, and the patient may notice no vision because the pressure has gone so low. So often the patients are kept in for a day or two, and maybe then their glaucoma treatment is held until the pressure in the eye slowly comes up again. So chronic open angle glaucoma is probably the one we're all going to come across the most, especially with the aging population and increase in people living longer. So this is your raised intraocular pressure, but it can occur without raised intraocular pressure. Patients have their Humphrey Visual Fields tests. I was always taught that a Humphrey Visual Fields test, having it done once off, yes, will give you an indication, but if there's peripheral field loss, but really you need to be doing several Humphrey Visual Fields, maybe 3 Humphrey Visual Fields across a 12-month or a 6-month period, monitoring the peripheral field loss, monitoring if the eye drops are working. So often someone who is attending a glaucoma clinic, when they come into OPD, they have their vision checked, they have their IOP done, and they naturally will have a Humphrey Visual Field test done straight away before they see anyone else. They may also have had the OCT image done just to see if the disc is enlarged or cupping at the optic nerve head. As I was saying earlier, the importance of patient education, eye drops. Please, 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 if you see a patient or you see a colleague, do not aim any eye drops at the cornea, or some patients call it the iris, or some patients call it the pupil, but it is the cornea. Please don't let patients aim eye drops at the cornea. It's not good practice. Don't let your colleagues aim eye drops at the cornea. It does hurt, it does sting, and if something hurts and stings, patients are not going to comply with it. I've only ever once been told where you put the eye drops onto the cornea, and that's maybe where there's a dendritic ulcer. And some people, I think it's more, I don't know how good the research is on this, but some people feel in practice that you're better off when it's a dendritic ulcer on the cornea, that the eye drop hits the dendritic ulcer first, because that's what you're trying to heal. But I think that's more anecdotal than actual evidence-based. I just put up here a list of some really good websites, and I'm not commissioned. As I said in the disclosure, I have no commission and I have no relation to any of these, but they're just some that I've used myself and I find really, really good. So it's just a list of some websites and some interesting reads and watches. So the NHS there has a really good website that explains glaucoma very simply, especially if you have a patient who's diagnosed. There's an absolutely fantastic glaucoma website. It's UK based. It's absolutely brilliant. It goes through glaucoma, gives loads of advice. They have regular podcasts. They have regular updates, and there's huge advice out there. There is advice out there at the moment. It's kind of new enough and it's still up in the air about different vitamins and how they support and help in relation to glaucoma. There is studies out there about B vitamins and different D vitamins and high doses and how they help with glaucoma. And there is, that website goes through some of that. And it also has links to equipment that can be used, and where to access equipment, where to access devices that can help with the input of eye drops. Then I just highlighted a name there, Professor Gus Gazzard. He is in Moorfields. He is the head of, I think he's the surgical directorate head in Moorfields now, but he's a professor of glaucoma. He has done huge research. He leads huge studies and research in the NHS with regards to glaucoma. He led in the selective laser SLT trabeculoplasty versus eye drop. It was a huge study done in the NHS. It's called the LIGHT study. I have a link for it here. Eye drops in the first line. I suppose NICE guidelines and most historic guidelines would always advise eye drops as the first line of treatment in glaucoma. And he was just doing a randomized controlled trial that was published in the Lancet of promoting the use of the selective laser trabeculoplasty in the treatment of glaucoma. He's fantastic. I've met him before, absolute gentleman, great teacher, and he's just really good to follow. Then I just highlighted down here the TEA professional site. TEA make an eye drop that a lot of us may have come across called Telos Duo. They have this really good website. It's on the UK website. It's the teapharmaceutical.co.uk, and they have an area for healthcare professionals. It's called the TEA Academy, and it's absolutely brilliant. When I started in ophthalmology, and I still dip in and out of it, there is online CPDs, there's online podcasts, there's online, you can just check in and out yourself, learning logs, different modules. It's really, really good. It's all at your own pace. They put up videos from previous conferences, and it's just, if you have free time, or maybe things are, I know it doesn't happen often, but maybe you're having a quiet day in work and you just want to hone in on something in ophthalmology. It covers all ophthalmology and it's absolutely brilliant, and you do get a cert. Unfortunately, the certs, I know they're CPD, but they're not in Ireland. The NMBI is in charge of our CPD. They're not NMBI approved, but they are NHS approved. But it's just a really, really good website, really easy, user-friendly and easy to follow, and I would definitely recommend it. Then just another website, or they have often a massive conference every year. It's MIGS, the Minimal Invasive Glaucoma Surgery, and they have a symposium every year. You will find parts of it on the TEA website, but it's just really interesting to check it out. And then the other one there is just a YouTube video about glaucoma and diagnosis. It has a lot of views. It's just very simple and very easy to follow. So then I was just trying to think of kind of a takeaway message if you were able to listen to me for as long as I spoke. I know I talk very, very fast. Apologies. It's just a habit I need to work on. But if I could give you anything, just if you could take away 3 things from this evening: the importance of history taken, not to be undermined. So important, getting your basic history from a patient. Start with your medication. When you get their list of medication, work backwards. Their medical history, their surgical history, and then their social history. So important. If you incorporate that systematic approach from the start and keep going with it, it makes life so much easier in ophthalmology. It took me a month or 2 to master it, of seeing patients every day, but it's just so important. Do it every time you meet a patient for the first time. Medication, medical history, surgical history, social history. Positioning the eye patient. Always have the patient in the correct position when you're checking their vision, when you're using an eye care, when you're sitting them at a machine. Big movements, then small movements. Always master the big movement first, getting the patient in the right position, chin on the rest. Is the patient comfortable? Are they going to be able to hold this position for 15 to 20 minutes? If the patient doesn't, it's a bit like the eye drops. If the patient finds it very difficult to do a Humphrey visual fields test, do you think they're going to come back in 3 months when it's meant to be repeated? So important, have the patient in the correct position. It can make huge impact. If another element there is biometry, when you're measuring a patient for their lens for cataract surgery, if a patient isn't in the right position when you're measuring them for their lens for cataract surgery, every 0.03 millimeters where you don't have the patient in the right position or you're off position by 0.03 millimeters, that's 0.1 diopters of a difference in the power of the lens. It is so important to have a patient in the correct position. And the final point is, as I was harping on about earlier, compliance with eye drops and how the patients put the eye drops in. And that is my talk. Thanks so much for listening to me.
Thank you so much, Emma, for such a beautiful presentation.
Thanks so much.
Can we all hear me?
Yeah.
Yes.
Okay. Thank you so much, Emma. That was a very beautiful presentation, and I'm sure most of us are taking 1 or 2 things from what you've said. Glaucoma is really it's a case that is really affecting so many people, and knowing what to do and when to do them is something that would help us as nurses to give our patients the best care. One of the things I took out today is we not putting the eye drop directly on the cornea. I've always seen that, and sometimes I talk, sometimes I just, but now that you've emphasized it, I think I'm going to speak up more and tell people, no, don't do that. It burns more. So this is the time we ask questions.
Yes.
If you have any question for Emma today, please signify by raise of hand, or you can type it in the chat box. I'm going to read it out.
Yeah.
Questions, anybody? Let's see. Someone is asking, I don't know if this really pertains to Emma, but this may be to Adebusola, that can we get certification of this webinar? I'm sure Adebusola will answer that when she comes on floor to say what is it called? To close the meeting, sorry.
Yeah, sometimes I think as nurses we overcomplicate what's really simple, and it took me a while to kind of realize. I had fantastic mentors and nurse mentors in ophthalmology when I first started, and one of the things that was drilled into me was keeping everything so simple. and that if you don't keep it simple and you don't get a patient on board at the start, you're not going to have the compliance in 2, 3, 6, 18 months time. So the eye drops, it's something so simple, putting the eye drop in correctly, but it makes such a difference.
You know, where I work in the OR, we do cataract surgery. And when I first started, because where I was coming from, we don't do more of eye surgery. And when I got in and it was cataract surgery, oh my God. For the first few months, I hated it. Number one, it's very fast. Number two, it seems so simple, but it's very delicate. You have to be careful of how you handle the lenses, how you put. I'm like, oh, so many things for such a simple case. But I think once you have a hang of it, you get it.
Yeah. And when you get into cataract surgery and scrubbing for it in theatre, when you become very good at it, it's very hard to leave it, because it's not physically hard, I suppose, compared to orthopedics, where there's huge equipment and antibiotics being drawn up and blood loss. And cataract surgery is lovely when you get into it.
Yes, that is very true. Very true. Now I enjoy it, and we had a surgeon move to another city, so we're looking at bringing in another surgeon, and everybody's like looking at me like, you be in the eye room, correct? Because nobody likes it.
Yeah, no, it's fab. But it's fast surgery. When it goes right, it is fast. But the satisfaction of meeting a patient maybe who had a very dense cataract and only 660 vision, and when you take their iPad off the following day and they can see, it's huge satisfaction, and patients are so pleased with the result. Yeah.
All right, since nobody has any question, I want to ask, what is the time frame that you think we should see our ophthalmologist to get her eye checked, especially as nurses? Sometimes we tend to I have any issues, and I think it's something we should really take cognizance of. That have a period of time where we get to the doctors to get our eyes checked and be sure we're fine. What time frame do you think that should be?
Yeah, if you're fit and healthy and you don't have any underlying problems and you've no family history, once a year is fine. Start off at once a year. It's a bit like going to the dentist, just once a year. And it doesn't even have to be the actual eye doctor. It can be just a very good, there's fantastic optometrists out there. There's some fantastic opticians, just once a year, and they will be able to advise you from there. Once a year at the start. It's kind of only until you start kind of developing problems, or there's a high risk of you developing an issue, maybe you need to be seen every 6 months. But at the start, if you're fit and healthy and you've no visual complaints and no family history, every year is fine.
Oh, all right. Thank you so much, Emma. I'm going to hand it over now to Adebusola. Adebusola, over to you, ma.
Thank you so much. That was an insightful presentation and very eye-opening as well. I must say, before I continue, I could see Danielle. Is that Danielle Hamad? I'm not sure. Is that Pakistan or what country is that? You have your hand raised. Can you say something and unmute your microphone? Danielle Hamad. I'm not sure if that's actually. Okay, maybe there's no question. I really want to say thank you so much, Hema, for honoring our invitation. Hema works with me in the department. We're in Nina together, ophthalmology, and she's very good at what she does. She's a specialist, and there's been rapid and significant changes since she joined the team. I just thought she needs to announce, to tell the whole world, like raise an awareness in terms of glaucoma and the treatments and more. TORG is represented by, there are 89 countries represented in TORG. This session is recorded, so when we publish that across TORG platforms, there might be more questions coming back, and there might actually be more requests to get you back to continue, and especially you mentioned OCTs and interpretation of that. So there's going to be another session over the next few weeks to continue from where you stopped if that would be okay with you. So thank you so much. And I really want to say thank you to the education and training team of TORG for facilitating and organizing this session. Thank you so much for doing a great job. And I could see some of my team. Let me just see, sorry, now I'm just trying to see. I could see Louise, she's one of our staff nurses in the department. I could see Susan, she's one of our staff nurses. I could see Nora. Nora is one of our CNSs. I wouldn't want to miss her, yeah. So Nora is a CNS ambulatory gynae. We work in the department together. I could see Geraldine. Geraldine Ryan is one of our candidates, advanced nurse practitioners. I might be bringing Geraldine in another few weeks because she's loaded as well. And I really want to say thank you so much. I think I could see a comment in the chat box. I'm not sure if I can see that now. Where is that? Sorry, one sec. So that comment was from Dr. Mays. Dr. Mays is one of the AORN leaders, chapter. She's based in the United States. So she said, great presentation, Emma. After 30 years in the OR and cataract and doing cataract surgery, I've learned new information. Well done and well done. And someone was asking, can we get certifications for this webinar? Yes. So if you go online on where you logged in, you can see there's a link under that says evaluation and certification. So when you fill that form, and then you can get your certificate, if that would be okay. And I could see Denise. Denise is from Kenya. Very amazing, Emma. Your presentation has made me to learn a lot. That's really good. Geraldine is saying excellent. Well done. Janet Flores. I don't know if that's an Italian name, or I'm not sure if that name is from the US. Thank you for the new learnings. So overall, it's been very insightful. Thank you, Emma, for sharing relevant knowledge. Thank you for joining us, and we're going to bring you back definitely. And based on more recommendations, we'll get back to you as well. And thank you for sharing the documentation.
Thanks.
We're going to be publishing that across our platforms. I know a lot of people couldn't connect despite the fact that we had lots of registrations. They couldn't connect because there was sudden change in the time zones and people were trying to actually kind of figure that out. Thank you so much. There's going to be another webinar in another 2 weeks. That is probably going to be from Rwanda. I think something on clinical research. I can't really remember now, from one of the from King Faisal Teaching Hospital in Kigali, Rwanda. So we're going to bring one of their leaders on board. We're going to continue from where we stopped exactly. So I really want to say thank you to everyone, every leader, every member. Thank you for connecting. And depending on your time zones, good morning, good afternoon, and good evening. Thank you for joining us, and hope to see you next time. Thank you, everyone. Thank you, Emma. Thank you.
Thank
Bye.
you. Thank you. Bye.
Bye, everyone.
Bye.